lingering in the background from the earlier presentation, especially on the issue of animals that are in quarantine. I don't know how the operative system is, but I would urge such countries to have a two-tier inspection system where the animals prior to getting into the quarantine facilities, if it's possible to do serological tests and clinical examinations of those animals so that they are sieved prior to entering the quarantine systems. And then right in the quarantine itself, then they can go ahead with the other checks so that those animals that are going for export can generally be said to be in a good healthy status, and the risk of exporting CBPP becomes minimum. Okay, we can go to the second slide, please. Now, as a preamble, I would say that generally lesions that are found incident to disease or any other pathological or physiological condition, these are lesions that are caused by the altering of the normal state in the chest or the lung cavity. It usually demonstrates the disturbance in the homeostasis of the thorax and the accompanying organs in there. You find that sometimes the blood pressure becomes affected. The oxygen levels in the thorax, in the lungs are affected. So you might see lesions that are incidental to that. You see body temperatures becoming high, and that will also have an incident to some of the lesions you are going to see. Now, this presentation generally does not look at a particular disease, though we have examples of lesions that you might see in particular disease conditions. We can go to the next slide. And these are generally very common that you find. You will find, say, hydrothorax, which is generally water in the thoracic cavity. If you look at on the upper side and generally in the lung cavity there, you tend to see that there's quite a lot of water in there. This can be caused by a number of conditions. One of them, hydrothorax, can be caused by, say, those countries that usually encounter East Coast fever. You will find this in East Coast fever conditions. You find HS, you find this condition. So these are general conditions that you see when the homeostasis is disturbed in the thoracic cavity. Next slide, please. So this is amplified. We just wanted to show you that you can see when you get another angle of this picture, you can see with the arrow pointing clearly where you find that hydrothorax. You find that the quantities of the water that you find are very varied. You could be very very little water that is not very copious per se. We find huge quantities of water that basically the thoracic organs are so-called, they are immersed in water, they're submerged in water. And at that time, the function of the organs in there will not be as effective as they're supposed to be. And you tend to see clinical signs in animals that have got that condition. Next slide, please. You will find pleural fluid, as Massimo was talking about, that you see later in the actual CBPP presentations. You see the arrow there, that is pleural fluid. This is a typical CBPP case with the pleural fluid, and you can see the uncollapsed lung there in the thoracic cavity. So the type of the hydrothorax that you see will also depend on the causative agent. And we know that in some diseases like CBPP, the water will be yellowish and looks like serum to demonstrate the differences that in the types of the water that you see in the thoracic cavity. So you need to look at what is the color of the water that you're seeing, what is the consistency of the water that you see, and what quantities do you have. They play a critical role in the diagnosis of the disease eventually, because like for CBPP, the pleural fluid is one of the key materials that we pick for the laboratory analysis. You can use it directly for culture. You can use it for PCR. So it's quite a very useful resource in diagnosis. You can also use it for differential diagnosis with the other that you find in other diseases that are not as pronounced. Next slide, please. You also have adhesions. These are very common in when there's a condition within the thoracic cavity. The adhesions vary with the type of disease that you're seeing and with the particular condition that exists at that particular moment. You will see this, I'm very sure, with Massimo's presentation later when he presents more on the CBPP. The one I'm showing you here is a typical one for CBPP. You can see that those adhesions are quite prominent, and they will vary in terms of thickness with and how they hold onto the thoracic cavity. This adhesion most usually is between the, as Massimo said, from the parietal pleural and the visceral pleural. So these adhesions normally are quite in CBP are very strong, and you might need actually an external to cut them when you're doing necropsy in the animals that you've suspected to have CBPP. These adhesions also can be found incidental, and the animal can be living normally because they might not really affect the animal, and there could be normal incidental findings, but they'll not be much in quantity and in size. They might just be as an incidental finding, very weak adhesions, and not really contributing to the pathology of the animal you are inspecting. Next slide, please. You find pleuritis as Massimo mentioned in CBPP, and it's very pronounced. And this surgical cutting of the animal, you can see in situ the lungs that have got CBPP, and the pleuritis, which is very pronounced on our right hand side. That pleuritis is very pronounced after removal of the plaque together with the lungs there. But when we have got the lung in situ, you can also see the pleural fluid still being available there for you to clearly see that we have this pleural fluid in the animals. And I should hasten to mention that these pleural fluids usually they tend to find them in the acute and subacute cases. As the disease progresses to the chronic stage, you might not find the pleural fluid in the thoracic cavity. Next slide, please. And you also find pleuritis in pasteurisis and Mannheimia hemolytica. You can see this is also pleuritis, and you compare with the one for contagious bovine pleural pneumonia. You see the actual difference, and you can appreciate that the two conditions, though with the same ultimate outlook, but they are quite different causative agents, and you will take interest that you don't seem to see the adhesions that were there in the previous slide, and the colorings usually are quite different, and therefore you can find these lesions in all conditions that you find in the chest cavity. Next slide, please. You can see now this is typical of CBPP, calcific pleuritis with necrotic sites that are caseous, and this is typical of CBPP. Also very important, as Massimo was saying, you have to look at public health as you do your postmortems. I should hasten to say that these lesions that you see, they would not all be the same, and therefore you have to have your hands as you do the inspection, hands onto the organs, and you have to evoke the sense of smell. You have to evoke the sense of touch, and your eyes are very important to discern what you see and record carefully within your mind to say, this is what I've seen, and it's a sense of further examination to find out what exactly is happening. Next slide, please. You find multifocal necrotic tracheitis, and this is maybe from Fusobacterium species. You see where the arrows are pointing there. These are multiple areas of necrotic foci, and you have to be, as Massimo said, as you're doing the postmortems, your eyes have to be on point all the time so that you do not miss these minute pathological changes that are there in the in the organs that you are inspecting. Next slide, please. Equally, there's still necrosis due to pasteurellosis. You can see where the arrows are pointing there. You find those are very important, but you might end up missing them if you are not very careful with your postmortem. But these are very common. You find them especially in some cases where you've got pasteurellosis, and you might end up missing them and misdiagnose, so to say, as you conduct your postmortem examination. Next slide. We have emphysema, which is of unknown cause. You can see the lung itself there embedded with air in it. And if you're not careful, you might end up misdiagnosing. Some of them might even say maybe this is CBPP. It's a very common, yes, you might suspect it, but you need to be very careful and learn to know the normal from the abnormal. This is an abnormal finding in an animal, but is it CBPP? You have to carry out further examination, and lung examination is one of the most important undertakings that we do in the examination for CBPP. Next slide, please. You can see the sensitivity of virus will show you this type of lesions. It's also, you can see on the right, on my extreme right, where you've got emphysema there, you've got air that is accumulated there. But if you look at the central part, you see also that there's a bit of reaction there, and if you are not very careful, you might misdiagnose it for another disease. So you have to really be, you have to know the normal, as I said earlier, for you to know the abnormal. And you have to know the particular diseases, what you are going to see and find in those diseases that are very prominent for you to lead you to start thinking of a particular disease. Next slide, please. We still continue with emphysema, and also here you see there's pneumonia, and it's also still the same virus. You can see on the extreme right here what is happening, and you can see that there's the lung pneumonia can be seen clearly in the parenchyma there. You can see what is happening to the lung, and there's a bit of change in the outlook of the smooth lung appearance, which we normally expect to this pathological condition that we've seen for this particular lung. Next slide, please. Yes, this is now, we can see that the edema in the interlobular septa there, you can see what has caused it. It makes the lung look distended in the interlobular septa. This is a normal finding, and you might not know the cause. Some of these are findings that you find during necropsy in the abattoirs. These are normal findings. These are findings that you need to investigate further to find out what exactly is causing this. You might need, especially in CBPP countries, you need to rule out CBPP most of the time when you find the lesions. It's better to assume it is CBPP and better rule it out from your diagnostic findings, so that you are sure that what you're doing is really ruling out CBPP, so that you know that you have really gone through the protocols that you're looking for. Next slide, please. Congestion in the calf lungs, it's you usually find it. You can see the way this lung looks, very congested, and you will have to investigate what caused this congestion. And for you to rule out CBPP, as I said, you need to collect very good samples, collect them aseptically as much as you can. If you are if you're in a place where you can manage to collect samples aseptically, but if you can't, conduct your investigations properly and ensure that you rule out CBPP from the postmortem findings themselves. Because in most cases in Africa, the most difficult part is for us to collect samples in the remote areas and transport them to the laboratory in a form and manner that will ensure the lungs reach the laboratory in where we can investigate further using the laboratory methods that are there. But if that is not there, you need to know the pathological signs that you're going to find that are typical of CBPP. And those will be explained to you later by Massimo, I'm very sure. Next slide. Yes, now you can see congestion again as the arrows are showing there. That's basically is just a congestion that is there. You have one non-region, origin. Sometimes it can be during the slaughter. Sometimes it could be during the terminal moments of an animal, and you've got these congestions that appear in the lungs. And therefore, you need to rule out any other pathological condition for those places, and they're good to collect samples from there from the lungs. Next slide. Enzootic pneumonia in the calf, you can see where the arrow is showing there, typical pneumonia, and you need to investigate the pneumonia. We know that enzootic pneumonia most of the time is caused by anemia, and so therefore we have to look at and try to isolate those to rule out any other disease that can confuse it with. Next slide, please. There again, bilateral aspiration pneumonia post-surgery. You see that this animal could have died during surgery, and then you had this aspiration pneumonia that occurred. Then you need to exactly know and examine the lung properly so that you rule out any possibility of masking of another pathological condition that exists in such a pneumonic lung. Next slide, please. Here's a slide that shows you the monolateral blood aspiration that occurs in an animal, and you can see the texture of the lung there, the way it has changed because of this aspiration that has occurred. And this is, as I said, it's going to the unilateral side of the lungs. Therefore, one lung will be affected, and the other lung might come out clean. Therefore, you need to look at this carefully and examine them so that you do not mask any other pathological condition that exists. Next slide. It's the same slide, just this one has been cut in there so that you can actually view it from the cut side, but it can actually typically of aspiration, so you can see the blood consistency that you find in the lung. Next slide, please. Now this is a consolidation that you might, if you are in a hurry and try to confuse things, this is consolidation that occurs. That can occur because of anemia and in pasteurellosis as well. So you can see that the lung is consolidated there, and you really need to take your time to ensure that you go through these lungs slowly so that you can rule out any other pathological condition and collect proper samples from here for further investigation when you are able to. But you can make a tentative diagnosis out there, especially if you do not have the necessary laboratory support that will help you to further elucidate your findings. Next slide, please. This is also enzootic pneumonia. You can see on the especially on the upper part of the lung, and it's bilateral. You can see that both lungs seem to be affected, but you can see that on the upper part there, it's more affected than the lower lung. So this is also very possible that you are dealing with something other than contagious bovine pneumonia, especially the two diseases that we can look at. It will either be enzootic hemolytica or bacterial pneumonia that you can see for that. Next slide, please. We still continue with the consolidation. You see now this is where we are looking at the whole lung, and you've got bacterial bronchopneumonia here. We know that this can be caused by Haemophilus somnus and also Mycoplasma species, other than Mycoplasma mycoides. Therefore, you might see this bronchopneumonia that you you will start in some cases in areas where you have not trained your staff properly, or you have got the community that is aware of CBPP. They might raise a false alarm sometimes and declare a disease which is at that low level, and think that there's an outbreak when of a reportable disease like CBPP, when it is such pathogens that can cause such a pathological lesion. So we just need, as professionals, we need to really examine these and rule out CBPP so that we are at peace. Next slide, please. Okay, so then the sensitivity of virus pneumonia, you can see how it's caused when they've got sagittal cut in the lungs, and look at the surface, the way it has come out. When you are not very careful, you might end up pronouncing CBPP in such a lung, especially if you're not very experienced. But you can see that you see the difference, what this poses, especially when you see the DDXs when they are presented to us. You see that such findings are very common for sensitive virus pneumonia. Next slide, please. Fibrinous pneumonia there, we can see that lung there, fibrinous pneumonia in the lung there, bilaterally in both lungs. So it's very pronounced, and you shouldn't be able to deduce that this cannot be contagious bovine pneumonia. But this, you can find these are common findings in cattle. Next slide, please. Continuing with fibrinous pneumonia, we've spent quite a lot on fibrinous pneumonia because we would want people to appreciate the fact that this can be misdiagnosed with CBPP in most cases, and you can see there with a section of the lung, you find that even the fluid does exist. You can see that there's some pleural fluid in there with thoracic fluid rather in there, and in some cases people might confuse this with contagious bovine pneumonia and report contagious bovine pneumonia when it is really actually fibrinous pneumonia caused by pasteuritis and mania. Next slide, please. You can see also fibrinous pericarditis, and as we're going to see later on, and you saw earlier in the slide that I showed with that fibrinous pleuritis which was there, this can also happen around the heart with fibrinous pericarditis, which is very, very common, and you need to be wary of such, and then not confuse it with contagious bovine pneumonia. Next slide, please. Now, this is quite typical of contagious bovine pneumonia. You can see, if you're not careful, why you can end up confusing the two. You see on my left, the lung, which is typical of a contagious bovine pneumonia, and you see the pseudomembrane that exists there on that fibrinous tissue that is on top of the lung there. So this is typical of contagious bovine pneumonia. If you compare with the last slide, you can see the difference which is there. That was on the heart, but this is clearly on the lungs. Next slide, please. This is a slide which is just showing the detailed investigation and shows the typical lesions you're going to see when the lungs are cut and magnified for you to see. Basically just showing us the fibrinous necrotizing pasteurellosis with septic thrombi there. We can see which is very typical there, and if you're not careful, you might end up confusing this with a sequestra, which is very normal for someone to confuse with, but you need to have that experience to differentiate the two.
I seem to be losing you, Geoffrey. Is it just me?
Hello? Hello, can you hear me? Can you hear me?
Yes.
Yes.
Very well.
Yes.
Okay. The next slide, the slides, I think the slides, I can't see them myself. Hello?
Sorry, I was kicked out of the meeting.
Okay.
Okay.
Okay. Mm. All right.
I think that's where you are.
Yes, this was the next slide, definitely. The mycosis, mycotic pneumonia, you can see what to present to you. And you need to really know the salient differences that you're going to see between this condition and contagious bovine pneumonia, which is important for you to reach your diagnosis just at the postmortem level. This is quite important because it demonstrates what confusions can be with just a mere sight. And if you don't have the experience and you don't record mostly your findings in your postmortem work, this is what leads to most of the confusion that you have. As Massimo explained, this form that he displayed in his previous slides, you see that once you record your findings, it helps you start seeing the pattern that you're getting in your postmortem findings, and then you know which of these appear more for you in the postmortems that you conduct. Next slide, please. This is a necrotic calcific pneumonia for TB, as we saw earlier on. This is very common in areas like Zambia and Namwala area. This is very common. You might find such findings in the abattoirs. This is it's a finding which as you decide what to condemn, this is one of those that you might end up condemning the whole carcass because of the inherent dangers of tuberculosis. Next slide. This is Mycoplasma bovis. You look at Mycoplasma bovis. This is demonstrated by this lesion here, which can be very confusing. You might look. You see when we look at the slides that will show the sequestra later on by Massimo. I'm sure it's not presenting that. You see, you need to take note of the difference between this slide that I've put here and the sequestra. Those that wanted to know how you can differentiate the micro sequestras, you might need to take note of this slide so that you can look at the typical differences that are there between the sequestra caused by CBPP and those findings that you might find in necrotic pneumonia by Mycoplasma bovis. You need to look at the differences so that you take note. Next slide, please. This is just a hematoma that you can find in a calf lung with bronchohematoma, where we've circled that ring there. It's usually a finding which you can sometimes confuse with the lesions for CBPP if you do not palpate properly and do further examination. We've put it there to demonstrate to say that, look, if it was CBPP, you could have seen attendant lesions around that area where you could have maybe adhesions. You could have had the lung texture change from what it is right now to show you that CBPP is present. But for this one, CBPP is absent. Therefore, you can find such they are common as you conduct your postmortem. Next slide, please. This is Echinococcus granulosa cysts. You can see those minor cysts that you find there. And these cysts are very common, especially in areas where there's the use of antiemetic is low. And for you to find them, sometimes you need to conduct very good palpation of the lungs as you conduct your examinations. And most of the times, it's better you do these are easily found most of the time before you do any cuttings on the lungs. So you use your lungs for feel and make sure you go right across the lung and through the whole length and breadth of the lung to ensure that you don't miss such cysts, which sometimes can be very small to touch. And sometimes they are big, so they come of different sizes. Next slide.
I'll request you to be concluding in 2 minutes. Thank you.
Okay, this is pericarditis and cardiomegaly, which can happen also in your findings, which is very normal. And I'm sure most of us have seen this before. Next slide. This is hemopericardium. This is blood around the heart. It's a common finding, but most of the time this might be traumatic. And also, you have to be very sure that you rule out any other pathological condition. Next slide. This is traumatic reticulopericarditis. You have to look at that, and you need to differentiate this from most of the time sequestra, because this most of the time might be septic and it have an extra smell, which is very rare for you to find in a sequestra. Next slide to demonstrate the difference between these. This is now a sequestra from CBPP, and if you check with the previous slide, the differences, you can see the ovate differences that are there. Next slide. Next slide to this. Thank you very much for your attention, and I can take questions if there are any. Thank you.
Thank you very much, Geoffrey. And because your presentation